Okay, thank you, everyone. I'm just going to give 1 minute just for us to settle down before we start. Okay, thank you so much, ladies and gentlemen. I would first like to welcome everyone for making it to this first oral session. My name is Akona, and I'm also co-chairing this session with Kathy.
I'm Kathy Matthews, and we're both from the Health Systems Research Unit. I'm just the timekeeper.
I didn't know that. You just said it now. Okay. Before we start, I just want to thank our wonderful speakers for today, for their time to be with us and just share knowledge with us. For this session, we have 6 speakers, but we're going to have 5 presentations. So each presentation will take about 15 minutes, and then we're going to take 1 or 2 questions if time allows after each presentation. I'm not going to be too strict, but I would like everyone to just guide their questions, just get straight to the point when you're asking the questions, and just remember to just say your name and where you come from. I'm going to move to the first speaker. Oh, I forgot. By the way, the topic for this session is the research to improve the lives of the vulnerable populations, as well as to enhance the quality health services and system. So the first speaker for the session is Prof. Asha George. Prof. Asha George is at the University of the Western Cape and also sharing in Sachi. She was also started the career in Mexico with the government ministries in the UN systems. Dr. George, sorry, is rated a B3 scientist by the National Research Foundation. And also since 2002, she's been co-edited in 3 edited volumes for journals, supplements, as well as co-authored in over 150 publications. Ladies and gentlemen, help me welcome Prof. George.
Thank you very much, Akona. And it's wonderful to be back here at the South African Medical Research Council. So I'm going to speak a little bit about some of the work I've been doing in gender and health systems. As Akona said, I'm very lucky to have come into the SARCHI chair, and I work with Helen Schneider on the extramural unit on health systems to services. Delighted to be here. So let me get started. Let me see, does this clicker? Good. So just to give a sense of what my SARCHI chair covers, I pivoted, I'm in my last year of funding, and I really pivoted to look at gender and health systems, where I'm delighted to be on this panel with colleagues from MRC, because we're also doing some work with the My Journey program in Klipfontein. So we were just trading notes on what that means. We're looking to do some work signing off on an NIHR consortium grant looking at violence against health workers in Kailicha from a gender lens. So really my SARCHI chair is looking at how do we invest in meaningful research locally that addresses gender issues and how health systems function, but also looking regionally at capacity across the continent. And I'm going to just touch base on the African community of practice on gender and health that we've been facilitating. And I'm going to present on some of the work I do in a global partnership on bringing a gender lens. We did some work on COVID-19, and I'm going to present, Michelle is here in an audience, on how We looked at how gender is integrated into government health programs. So our work is more at a higher level. I think some of the presentations are going to be looking at specific interventions, and we're looking at how do you bring gender into broader systems. Let me just say, why is this important? So governments have really committed to gender equality a long time ago. But there's been overall a lack of progress in really achieving results. And I think more recently, what's really been a concern is a backlash. We are in a time of political backlash on gender equality that's manifesting in many different ways. And the health sector is important and has a responsibility, not just in being responsive to the needs of vulnerable populations, but because it itself can act as a determinant of social justice and has a role to play in that sense. And so that's why we're looking at what's the role the health system needs to play in terms of responding to gender inequality and redressing that. So that's the topic, the what. Why is this important? I thought I'd take an opportunity to say how we do this is as important as the what. And our colleagues talked about feeling and connecting it to how we do the thinking. It's ironic to me that work on equity can be done in inequitable ways as well. And so some of the work, Walde's here in the audience behind, we are doing a scoping review of who's doing research, what has been the research applying a gender lens to sexual and reproductive health and maternal health on the continent. And it's really striking. In the last 10 years, if you look at, does the pointer work here? So all the work is based, our scoping review was on Africa. So quite a lot, a huge contribution South Africa makes. But if you look at leadership positions, and many of you will have seen this, but I think it's still, I really think evidence synthesis can't happen anymore without taking a critical look as to these dimensions. It's mostly authors in the US who are first and last author. And South Africa, again, plays a huge role on the continent. But it's a complete reversal in terms of where the research takes place and who leads the research. And I just think in the field of, if you're doing research on inequality, the partnerships itself can't be unequal. We need to, for it to have impact, we need to look at not just knowledge translation as a technical process, but who is shaping the research agenda? Who is continuing that legacy and interacting with local communities, with policymakers, with colleagues in the health department to take the agenda forward? And that has to be locally owned. So the how this is done is really critical as well. And I just wanted to bring that. Interestingly, at least half of the South Africa bloc comes from the MRC. So I think some real analysis of who's doing knowledge production and how is critical in this field. So I'm going to talk a little bit about this collaboration. Michelle is in the room. We looked at, and we were a network of colleagues who have known each other for a long time across India, Niger, Ethiopia, Kuala Lumpur, Malaysia, and the Philippines. A lot of networks of people who have been part of the women's health movement, who were interested in knowing what's the result of our advocacy over all this time. There's a lot of work that has happened in terms of, we know this is critical, and there's no time that's more critical than now, actually, in terms of we're not just in a crisis of lack of access, there's climate change, humanitarian crisis, so that's why we tend to talk of polycrisis. But really, it's a time in which we need to strengthen the systems that we have. So that was part of the impetus of doing this work. And there's actually a lot of evidence base as to what works. But what we found in the literature is that it's a lot of research that focuses on interventions. that are happening and initiatives that have been successful but are done at small scale and mostly by NGOs. So the question we had was, how do we, if we really want to have impact at scale, it has to be engaging with government. We really can't afford these boutique interventions that are supported, that have successful results, but then are not implemented afterwards. So what are the initiatives that have really worked across at national scale to have impact? So we set about doing a crowdsourcing initiative. I think part of this research is trying to raise awareness and engage interest. So we did do a literature review, but we also opened it up. We went to social media, sent it out on email, and said, send us examples of programs. And so we have a map that was published and a database, and there were over 51 programs that colleagues sent us saying that we brought in a gender lens in a large program. What was striking to us is once we did some further work as to how long the intervention was government really involved or not? Was it in health? That database of 51 shrank to 6 or 8. So I think there's a lot of efforts to make impact, but once you take a more critical lens as to who's actually doing that work, is it something that's government owned or not? Is it at scale? Is it something that's really in the health sector? It really shrinks down again. Nonetheless, we did this work. We did find we also picked very diverse country contexts and initiatives. So in Niger, we looked at the École de Marie initiative, which is in English the husband school. It's an initiative to work at community level to engage men in sexual and reproductive health. We looked at Ethiopia. Ethiopia published a gender mainstreaming manual in 2002 and has had decades of work at the Ministry of Health of trying to mainstream gender in national planning. So that was one of the examples. For over 10 years in India, there's been an effort to mainstream gender into medical education. So we looked at how did that happen, who led that, what were the processes. In southern India, there's been a lot of change, and government is taking on having gender guidance clinics. That's bringing clinics for the trans population in mainstream health services. So that was another case study. In Nepal, we looked at what was the mobilization that led to shifting legislation and legalizing safe abortion. So big policy changes, as well as looking at what happens in hospitals. And in Philippines also, it was a large regional hospital. How did they take on this agenda? So really diverse case studies. And what did we learn from doing that work with in-country partners and all of us linked together? This was sort of a way there were lots of discussions, interviews, document review. This is too small to present here, but it's really taking a health systems lens on looking at the context, what were key catalysts and mechanisms for change in really having an impact with government, to really have an impact on health outcomes and making services, systems more responsive to gender. I thought what I'd do is take a step back and just give you high-level comments on, not present you with slides with lots of detailed text or numbers, and give you high-level findings. So what was key? I think I put here people, but it's people with passion, which was very much in the room this morning. It was people, champions that were involved outside of government and inside of government. What was really striking was there are women's NGOs that have been part of this journey. The medical education effort, Sehat was a feminist NGO that had been there doing this work and started to broker partnerships with key actors in the government. They had a key champion in the director of medical education. And so it was partnerships with people outside and inside coming together. Same with Niger. There was Songes, which is an NGO that helped broker the community-based level with government and donors. So an inside-outside strategy. You need legislative backing and policies. In Tamil Nadu, you had the Transgender Rights Act come in. In Ethiopia, you had multiple policies. So people worked on that, used that mandate to effect further change. But they also worked with processes. So there were multiple structures, working groups, informal processes as well. In Ethiopia, every year there's a gender and health forum convened by government, donors, and civil society. So there were consultations. It's working over time using various structures and processes, setting up an architecture to really affect change and have those relationships. So it's both formal and informal. Prof. Musa talked about semantics, but framing is really important, and communication. I think there was a student here who said communicating reforms. What was key in Niger in getting buy-in was, someone said health promotion was about family planning. That was what got the attention of policymakers in Niger, was the low utilization of family planning, the low access to health services. And so it was an instrumental argument. And the same in Nepal on safe abortion. It was maternal mortality was so high. So they used health data in a strategic way to convince them that something had to be done. So that framing is absolutely key in shifting the narrative. Funding. So people think about funding, and Musa kept saying there's budget, there's not budget. What was interesting in this work was it wasn't just monetary, the amount of funding. They also used funding in a political way. It was often national officers in funding agencies that had a passion for this, that used the donor lens as a legitimizing angle to bring partners together. So it wasn't necessarily the amount of money, it was using funding to convene and bring people together and form these partnerships. And I put information, I was looking for 4 Fs, but documentation, monitoring, evidence did have a role. Not necessarily sometimes in sparking action, but it really was helpful to have evidence feedback as the reforms went forward, to look at what were the blind spots. So I really think the call this morning of what are we doing with NHI and the call for research to inform what are the implementation gaps, that's exactly what these partnerships did to push the agenda forward. Was it successful? I think with all of these, we left with amazing examples of large-scale programs that really attempted to do this, but they were all partial successes. The collaboration initially was going to be best practices, and then we were like, well, these are promising, but not necessarily. They didn't accomplish everything they wanted to do. And I think there's, as much as you go for scaling up, there's a lot of challenges in connecting the dots and making sure that reforms that happen in one area of the health sector connect to the other. So for instance, in Tamil Nadu, there was a lot of development of respectful care, but in the same hospital, they didn't have respectful maternity care. So looking at how you can have islands of success, but how do you take that learning and spread it broader within that sector? And ultimately, I'm wrapping up, a lot of this led to a lot of push by activists, advocates outside and inside the government systems. But there's also a sort of a sense, a tension on how transformative these large-scale programs can be. Because ultimately, they are about the nitty-gritty of budgets, people having to make decisions on day-to-day basis, operating within, what do the guidelines say, training, the turnover of personnel. So there was a tension there of like how far, what our expectations are, and what does it take to affect change. What was striking was accountability structures for these programs were largely soft. As much as you had all these things coming together, I think that was one thing. It relied on really the passion of champions to work to develop those relationships and push the boundaries of what those programs were doing. And I just wanted to end because we really wanted to look at what was at scale and sustainable. And Mary Kinney, who's here, she looked at PIP in some work we did documenting the history of PIP in South Africa. And really the lesson we learned is reiterated here. We think of sustainability as something that a program is going to be sustainable if it has X, Y, and Z. All these programs achieved remarkable gains, but they're living beings. If you don't have constant input into them, they fall apart, and especially when they are going against the grain. So a key learning is you can't give up, that it's a journey that has to continue, and you need ongoing support through these multiple ways of coming together. I know that was very high level, and I said I was going to keep it at that, but I hope that sparks interest, and I hope it resonates. We can pull these threads together at the end of the panel. Thank you.
Thank you so much, Prof, for this mouthful presentation. Just going to give maybe one question if we have, and then we'll move quickly to the second speaker. Okay, thank you. I think we should move. Our second speaker is Dr. Christiane Howard. So Christiane Howard is a UK-trained family physician working in South Africa for over 20 years. And also she is a senior researcher doing extensive research experience in the field of maternal and child health, nutrition with a focus into feeding, skills development, community health, and implementation research. Ladies and gentlemen, let's welcome Prof. Christiane.
Good morning, everyone. Ooh, I can't see my slides now. So I'm going to shine a light on a particularly vulnerable population, perhaps a population that we don't talk about very much, children on the move or unaccompanied migrant children, in this case from Zimbabwe to South Africa. So this work was funded by UNICEF Zimbabwe, and it's part of an intersectoral multi-stakeholder collaboration based in Zimbabwe to address the issue of unaccompanied migrant children. And we worked with Prof. Hatloy from FAFO in Norway and also Prof. Harasvicha from the University of Zimbabwe. So there was data collected in Zimbabwe, but I'm only presenting data from children that were in South Africa and that we interviewed in South Africa. There's a certain amount of sensitivity about presenting Zimbabwean data as a non-Zimbabwean. Okay, so this work was done last year between May and July. We interviewed children who had travelled from Zimbabwe to South Africa on their own without an adult when they were aged between 12 and 17 years. I'm just going to say that we use the word children. That's the sort of language that is used rather than adolescents or perhaps other terms that people would use. We conducted our interviews in shelters and hostels, in the street and in the community. We used field workers who were two Zimbabwean female PhD students who collected the data, both in border areas and in Johannesburg and Pretoria. we had a lot of support from NGOs, from DSD, in locating where we could find these children, but recruitment was very challenging. The children are quite hidden. They don't wanting to come and talk to people. They're concerned about being deported back to South Africa. And in many cases, we were working in areas where there were quite a lot of security concerns for our staff as well. All participants provided informed consent, written informed consent, unless there was a responsible adult there, which in most cases there wasn't. So who were these children? They were aged between 12 and 19 years, so we did have some older children who had travelled when they were younger, so they were able to report on that. As I said, we interviewed in the street, shelter and the community, but we actually only had one child who was actually living on the street at the time that we did the interviews, although many of them had stories about living on the street. So 6 children were living with members of their family, so had been able to get in touch with members of their family, but those were the minority. So some children living with non-family members, usually the employer, or renting a room for themselves, working and paying their rent and living in a room on their own. Then we had 12 children who were living in shelters at the time that we interviewed them. And just to highlight a little bit else about them, 7 out of 33 interviews that we did, the children were going to school. So we had very few children who were able to access schools in South Africa, and very few had also been attending school in Zimbabwe before they left. Again, few children were living with any biological parent before they left. So 10 out of 33 living with a parent. And in fact, there was only one child who was living with both parents before they left. So the reasons for leaving home, the sort of biggest thing that overarched everything were family dysfunction. There were some really harrowing stories around what the family backgrounds were for these children. They were often their parents had died, both their parents had died, or their parents had often abandoned them. A lot of people have come to South Africa, parents had left to come to South Africa and had lost touch with them. Poverty and hunger, lack of opportunities perceived in Zimbabwe about not being able to attend school, and in some cases abuse within these families. So these were really very difficult stories and backgrounds. Looking at why they came, everybody was looking for a better life. They looking for opportunities for work, for education, to send money home, to join up with family and friends. And they often had a lot of influence from people who'd already left and gone to South Africa to really see that South African streets were paved with gold. So they really perceived coming to South Africa as being the answer to all of their problems. Oops. So some of the reasons for leaving, here some of the quotes. The first child says, "The issue of starvation was the problem. There was a strong narrative of hunger in the context of Zimbabwe." The second child, "My parents passed away and I started to stay with my grandmother, and then my grandmother passed away." There were a number of children who were really completely alone in the world and who came to South Africa to look for a better life. Then the last quote again was a very common story, that the mother of this girl had a car accident. She was in a wheelchair. There was nobody bringing any money in at home, so she felt she had to come to South Africa to be able to support the family. So then to get here, they had to cross the border. So these are young children crossing the river, walking through the forest where there are police and there are patrols patrolling the forest, coming across the railway line, or coming in a bus or a taxi. They faced soldiers, police patrols, possible detention and deportation. Violence and theft was pretty much universal. Most of them had stories of having things stolen on the way, and sexual violence. We had 2 girls who were raped actually during the process of crossing the border. That seemed to be a very common event. But if you think about this kind of level of resilience and agency that these children showed, They've made friends with people. I think it was a strong narrative throughout the interviews that these kids, they met people, they linked with people who offered them shelter or money or helped them along the way. And they often travelled together across the border. They found out the criminals who traffic people across the border. They found those people, linked with them, negotiated the payment, worked in the border towns to get the money so they were able to pay, and then gave the money to adults for safekeeping in many cases to get across the border. So these are children who are not perhaps the same as some of the other children that we know. These were kids which really showed a lot of resilience and agency. So just looking at a couple of the stories here, I mean, they are really harrowing. The first child, she was scared when the policemen on the South African side had dogs. They came into the bus and asked for passports, so she was told to be quiet, and she managed to hide with the help of the other people on the bus, so she was able to get to South Africa. The second story is around coming through the river, which again was very common. In fact, it was the commonest way that people came across the Limpopo River. He was there while they were negotiating the payments with the soldiers and the police that patrol there. And then he got into the river and was about to drown and had to be rescued. So, these are very harrowing stories. Then they come to South Africa. How did they arrive? They arrived in a border town, and many of them were hoping to join with family and friends. But often they didn't know where the family members were. So they ended up living on the streets, begging, and some went to the shelter or the hostel. Usually they were taken to the hostel by members of the community or the police rather than going there voluntarily. But a lot of the children lived in the community. They found jobs, they paid rent, they found somewhere to stay, the employers helped them with accommodation, and they rented rooms. So they managed to find a life in South Africa. And you can see here in some of these stories, the first child, he was picked up begging in the street and taken to a shelter. The second one, this is a girl who was living in the girls' shelter in Messina. So she was able to play with others, go to school, get help with her homework. So there were a number of children who actually did find the services that they need and were able to get back to school, get healthcare, and achieve what they set out to do. But the third story, not so great, from the boys' shelter, where this particular boy, he was the one who lived on the streets. He ran away from the shelter because he was beaten up and his things were stolen. They took the food from him. So he was living in a petrol station with some other children in Messina. Right, so work was the number one reason why people came to South Africa, why these children came to South Africa. They did every kind of job you can imagine, selling anything, airtime, food, snacks, doing construction work, gardening, herding cows, all kinds of jobs. And often they would have 2 or 3 jobs. They would have a job with an employer. When they were finished with that, they would do their own work. And they were quite open to abuse from the employers, low wages, because the people knew that they didn't have status and documents to be able to make any kind of complaint. And also they were young children working. But in many cases as well, the employers were the lifeline, the support for these children. They gave them food, they gave them safety, and they protected them. So it was kind of a mixed blessing. But a lot of children were working and still finding themselves hungry at the end of the day. So just some examples. I think this top one, this is a boy who had left the hostel because he wanted to be able to work more. And in the hostel, you're not allowed to work. But he continued to go to school. He budgeted his time. He had a job. He went to school. And he was managing to look for his own future. The second girl is doing sex work now. And she felt that she had no choice. That was her only way out and the only way to survive. So they were very contrasting stories between the different children. Then the third quote is from a girl who came to South Africa and worked as a domestic worker. And she eventually, the husband in the family was threatening to harass her, and so she left. She took the money she saved, and she was able to get a stall in a market, and she was able to earn her own living. Last one, sleeping on an empty stomach, very common. Okay, so just since we're talking about access to services in this session, just to quickly run through all these legal things that we all know about: Convention on the Rights of the Child, the Constitution of South Africa, the Children's Act. All these things protect these children. These rights for education, for health, for safety, for accommodation, for food are unalienable rights within South African Constitution, within where we are here in South Africa. So why are we getting these stories that I just shared with you? Oh gosh. We have oh, for heaven's sake, sorry. Oh. Put it down. Okay, so the South African Constitution doesn't have provisions for how to manage unaccompanied children. The Children's Act doesn't specify mechanisms. The police fail to adhere to the policies. Public school admission requires documentation. And in fact, the Immigration Act specifically prevents unaccompanied children without legal status to be admitted to schools. And in terms of health, it's mainly practical challenges, particularly for non-emergency or specialised care, lack of someone to provide consent, which causes problems there. But amongst our participants, the only children who were able to go to school were those who went to the hostels. And there were also a couple of children who left the hostel and continued to school, but actually out of 33 children, only 7 were in school. So they didn't succeed in getting their education, unfortunately. And even those hostel children often didn't have access to books and clothes that they needed. So they were not able to get into school, despite the fact that they were in the hostel. In terms of healthcare, sheltered children had no problem. They had access to healthcare. We had one participant who'd had a baby. Since being in South Africa, she also had access to healthcare. She didn't report any concerns about getting healthcare. But most non-sheltered children thought they would not be able to access care without documentation, so they avoided going to health services. But there were a few who'd been sick and had been I'm just about to finish, who had been able to access healthcare. None of our children, and we asked all of them, suggested that they'd been refused access to care. Okay, so this is just an example. This is a girl who was raped at knife point by somebody who was a friend of her employer. And so she went to the clinic and reported what had happened. And so she went there, she got a pregnancy test, she got the services that she needed, and she was able to explain what had happened, but she didn't want to go to the police. She was too fearful of not having a passport, so she wasn't able to access the police. So in conclusion, hold on, go. That's right. So, I mean, the unaccompanied migrant children are a hidden group of children who are very, very vulnerable, where the law already protects them, but in practical terms, implementation of protection for these children is not happening. These are children who display the most extraordinary ability to adapt to their circumstances, make the best of things, and really we need to have solutions that can take account of their agency and the people that they are and provide them with the protection that they deserve. Thank you.
Okay. Thank you so much, Dr. Howard. Such a mouthful presentation. And I think one thing that I take from the presentation is that a child is a child regardless of their migratory status. I'm just going to give time for questions. Okay, we have one questions there. Okay, I only see 2, and I think I'm going to take 2.
So this work was, as I said, it was funded by UNICEF in Zimbabwe, and we worked with NGOs and people in those areas who were working with these children. So we linked them with services whenever they accepted that we could do so. So if we found children that needed care, needed healthcare, we facilitated that, but obviously we can't do anything against their will. So we offered them services, we gave them information about the services that were available to them, but we weren't able to make people do things they didn't want to do.
Thank you. Really heartbreaking, and takes me back to Young and I's previous lives as social workers in Cape Town. And I think the main thing I wanted to point out is that actually the biggest problem here is that even for South African children, the system is unresponsive. Everything you've outlined here, that's exactly the experience of South African children on the streets. It's right down to the fear of interacting with the police or the people and actors who are actually supposed to help and protect them, because the CPS system is so dysfunctional and broken down. No child will present at a health facility, even if they are South African, because they fear that as soon as they do, they'll be taken back either to the dysfunctional situation they've escaped or be placed in foster care, which is even worse. For years, Young and I worked, when we were at UCT, we worked with street children in Mowbray. And the rape, all of the harrowing stories you've just explained, that was happening, and those were the South African children. And there was almost no way out for them, really. So I think until we're able to bring, I think it just shows if you have a domestic system and situation that is not protective and responsive to children's needs in general, if you bring in then migrant children who are even more vulnerable, there's no hope for them. There's no hope of that situation being resolved. And then I wanted to ask, sort of related to the comment that was made by the previous person who asked, what was UNICEF's purpose for conducting this study?
I think the sort of default response for these children is to send them back to their families. So if they do make themselves known, then the process is that to repatriate them, send them back to Zimbabwe and back to their families in Zimbabwe. So UNICEF's stance on that was to say these children are not sort of just defenseless. These are children with a lot of agency and determination, and that different solutions are required for that. So really the engagement was mainly on the Zimbabwean side and working with the Zimbabwean government, looking at what solutions could be put into place to provide more tailored and child-centered solutions for some of these issues. But it's obviously very difficult. You need to get rid of poverty and family dysfunction and those things. But that was their motivation, was to try to change the focus from these children as being passive, rather to say that we need to respect their agency and think about more complex, nuanced solutions for this.
Yeah, thank you. I would really love for us to continue with this conversation, but because of time, we are now moving to our third presentation. Dr. Kim and Dr. Zoe. We all know Dr. Kim. They're both from our unit. Dr. Kim is a specialist scientist in the Health Systems Research Unit here at the South African Medical Research Council. She leads research focusing on adolescent, youth, sexual and reproductive health. She has over 10 years working experience leading as a co-PI and a PI in several large cross-sectional studies. When it comes to Dr. Zoe, she's also a socio-behavioral researcher focusing on sexual and reproductive health. She also leads several qualitative research studies. She also an honorary research associate in the University of Cape Town. Let's welcome them.
Thanks. I think I'm a bit short. Thanks. Where's that? Okay. Thanks, Akona. Good morning, everyone. So as mentioned, I'm Kim, and I'll be presenting today with my colleague Zoe, who's going to take over for the next half. So we're presenting a study that evaluated the My Journey program, which you may have had hints of it earlier on. The My Journey program is one of the two largest combination HIV prevention intervention programs being implemented in 12 high-burdened HIV sub-districts in 8 of the 9 provinces in the country from 2016 until currently, and is being funded by the Global Fund. The goals of the intervention include to reduce HIV incidence, teenage pregnancy, and gender-based violence among adolescent girls and young women, and increase retention in school and access to economic opportunities for them. So the HASTORY 3 study is the impact evaluation of the My Journey program. We call it the HASTORY 3 study, and it is a mixed method evaluation. And in this presentation, we will focus on the preliminary findings because we've just completed the study in about 2 months ago, and we're still busy with the write-up. Okay. So the aim of the HASTORY 3 study, as mentioned, is to evaluate the impact of the My Journey program with the primary objective to determine the intervention impact on HIV prevalence among adolescent girls and young women. These are other objectives of the evaluation, but I won't describe all of them due to the limitations of time. We've listed them up on the screen, but for this presentation, we'll focus on the main ones, which is one, the primary objective, the HIV prevalence among AGYW, and secondly, the coverage of HIV and other SRH services for AGYW. Okay, this evaluation is a non-randomized controlled trial conducted in 48 sites, which is 24 intervention sites and 24 control sites. We've collected data among AGYW using a computer-assisted audio. We had tablets in the field, and we've also taken their blood for the purposes of the primary outcome. Okay, these are pretty much the short summary of the findings, and I'll go too much into them. Essentially, we've got 5,025 AGYW who completed our survey, and this represents a 97% response rate. The mean age of adolescent girls and young women was 19.1, with the HIV prevalence at 9.5% in the intervention sites and 10.5% in the comparison sites. So we've produced HIV prevention cascades for the participants who were not living with HIV and at risk for HIV. On the slide, you're seeing the HIV prevention cascade for PrEP. So I'm going to shortly describe what you are seeing on the screen. So we have the first bar, which is knows about PrEP and ever offered PrEP, and then ever used PrEP and self-reported currently using PrEP. So the blue is the comparison sites and the red bar is the intervention site. This slide shows that the HIV prevention cascade for PrEP for adolescents 15 to 19 years of age would show a substantial increase and significant differences in favor of the intervention, which is a red bar. 22% of adolescent girls and young women, in fact, the girls in the intervention had used PrEP ever, compared to the 9.6% in the comparison arm. Now, the study obviously produced an overwhelming evidence that the My Journey program substantially increased the coverage of PrEP among AGYW who are not living with HIV. As you can also see in this graph, that this is a 20 to 24 AGYW graph, and it has doubled the uptake of PrEP compared to the comparison sites. And now, with regards to the cascades for condoms, there was no intervention effect on motivation to use, access to, and effective use of condoms among participants who were at risk of transmitting HIV to their sexual partners. This is based on the self-reported living with HIV among our participants. Okay, same here. This is for the graph of the 20 to 24. Not much difference on access and use of condoms. With regards to pregnancy prevention cascades, my journey program only had, or probably had, a small effect on the coverage of contraceptives. We found no intervention effect on the use of modern contraception other than the condoms among participants who had ever had sex in the study, and there was no difference between the two sites, intervention and comparison sites. Okay, and the last with the 20 to 24 age group of the pregnancy prevention, also there was no differences, but AJYW in the intervention sites had fewer barriers in accessing contraception services, but coverage didn't make much of a difference in terms of the uptake. And that's really highlights that there more needs to be done in terms of preventing unintended pregnancies, as that makes the young woman's life even more difficult to navigate an unintended pregnancy. To conclude the quantitative aspect of the study, the findings of this non-randomized control trial have shown that the My Journey program has made a major impact on making PrEP accessible to AJYW, which will have a positive impact on the lives of these young women. I'm now going to hand over to my colleague Zoe.
Hi everyone, thanks. I'm Zoe Doobie. I'll be presenting the qualitative component of the Her Story evaluation. Oops, I see what this issue is now. Okay, so the objectives of the qualitative study were to describe the acceptability of the My Journey program amongst adolescent girls and young women who had participated in it or had been in the intervention communities, and to describe the self-reported impact of the intervention on their health, on their well-being, and their lives in general, and the experiences they had with various of the intervention components. We also sought to describe the experiences of other stakeholders. Oops, so I'm going to focus on just these interviews that we conducted with adolescent girls and young women. So we conducted interviews in the intervention districts only. We didn't look at the control communities. We interviewed 68 adolescent girls and young women who had participated already in the survey, in the Her Story 3 survey. That's how we got hold of them. So we had 13 girls in the younger age group, 15 to 17, and a larger number, 55, in the 18 to 24 age group. And the qualitative data was analysed thematically. I won't go into too much detail on that. So I'm just going to look very broad overview of what some of the preliminary findings from the qualitative show. Adolescent girls and young women reported themselves that they, from participating in the intervention, there had been positive behaviour changes in themselves, which they described. There had been financial and material benefits to participating, increased sexual and reproductive health information and knowledge, health benefits, mental health and psychosocial benefits, and educational and career benefits. And I'll just be describing these in a little bit more detail now. So what were the positive behavior change benefits that they described? Young women described that their self-esteem, self-confidence, and the awareness of their rights had increased since participating in the intervention. They had improved attitudes towards life, so sort of more positive outlook, and this also touches on the mental health aspect. They described, which I found quite interesting, reduced homophobic and homoprejudicial attitudes, just some of the intervention components they'd participated in. And many of them described that they were now using their spare time more constructively and drinking less alcohol. So in terms of the sexual and reproductive health education benefits, and this speaks to this PrEP knowledge slides that Kim presented, the young women described that their sexual and reproductive health information had improved. They had better knowledge around STIs, HIV, pregnancy prevention, etc. So that was one key perceived benefit of participating. They also described that they had previously felt unable to get SRH information from parents and caregivers, particularly relating to how to have safe sex, the process of adolescence, and around HIV and PrEP particularly. Broader health benefits they described: improved access to health and diagnostic tests for a range of health issues, improved access to contraceptives, high quality, youth-friendly, and this is a really important point. They described the youth-friendly, non-judgmental, comprehensive health services that they now access as a real benefit. Improved access to support for the most vulnerable young women, and access to menstrual management products. So just a quotation presented on the right. You get all the services. Everything becomes easy when there are such programs here in the villages. Mental health and psychosocial benefits was a massive piece of our findings. So young women described improved access to psychosocial and emotional support from trained staff and from their peers, improved ability to articulate their mental health needs. And this was a particular finding that young women felt previously they didn't know how to access support, how to put their feelings into words. And this all reduced feelings of emotional isolation. Narratives suggested improved mental health resilience. Young women described having a more positive outlook on life and, crucially, having more hope. So some quotations. I felt like there are people out there that care. I felt cared for, that there are people who take an effort for me. They make me feel better in a safe place. They make me feel more comfortable and make me realize that I'm not alone. I felt like a loved person. You could talk to them and they would not give up on you. These are quite powerful quotations. Educational and career benefits. Young women described receiving assistance with applications to employment, developing CVs, applying for tertiary education, assistance with their homework, and starting up their own businesses. This quotation, it can unlock our lives and see what we can do and how we can succeed in life. So young women really felt that they could now realize their potential and they had hope in that. So just concluding, young women really felt that these programs do increase their access to really important sexual and reproductive health information, so they can understand the importance of preventing pregnancy, delaying childbearing so that they can finish their education if they wish. It improves their health-seeking behavior and ability to access psychosocial support, which is crucial. They felt that their participation builds resilience, helping them have more positive outlook on life and increasing their sense of hope and motivation for their own futures. And the health benefits of their participation focused on improved access to youth-friendly, appropriate services and commodities. So that's the story in a whistle-stop tour. Thank you very much.
Thank you, colleagues. Again, I'm just going to give some time for questions. Okay, we have one, and I can see one at the back.
Thank you very much. And I must declare my conflict of interest. I was very much involved in Soul Buddies and Rise Young Girls. So just I think what's stark about this great evaluation, and congratulations on the hard work and the good work that you've done. And what's stark about it is qualitatively, it's a wonderful program, and quantitatively, there's absolutely no difference. And for me, what it illustrates and what we've been trying to say is that it doesn't actually depend on HIV education alone. And we cannot seem to push past this issue that HIV prevention is not about how many times you tell somebody to prevent. It really is about the structural issues, and it's about, we know what the gender issues are, we know about how, anyway, you know the whole story. But for me, we haven't, and it's a very, very frustrating for I was working in this field for 20 years, and we still haven't pushed past this issue of educating about HIV.
Thank you. I think that's more of a comment than a question. Okay.
Thank you. I'm Lungi Songongi from Stellenbosch University. And thank you both for a really insightful and comprehensive evaluation. And Sue has sort of taken the words out of my mouth, because I'd noted down here that the coverage was as high as the discontinuation. And first I wondered whether, I was a bit surprised that in the qualitative findings and discussions, there wasn't an exploration of that from the perspective or from the voices of the youth themselves. What were their experiences and what were the reasons? But for me, as a research community and as a health economist, it also had me wondering about how we measure the impact of interventions. In the morning, there was a talk about social determinants of health. And so here is an intervention that has perceived benefits on other aspects of well-being for adolescents, but does not have a strong impact on a particular outcome. How do we design economic evaluations or other evaluations that have a multiplicity of outcomes? And when we make decisions about what are the appropriate interventions to take on board, do we also consider those that address some of the social determinants of health? How do we deal with interventions that do not have that haven't showed a strong impact on a clinical outcome, but has other positive outcomes?
Can you know?
Just
Okay, I'm going to be very short. Yeah. I just want to add to what Lungi has offered, to say that I wonder to what extent are we connected to what it is like for low-income AGY to negotiate life in circumstances of chronic ongoing trauma, dysfunction, and chaos. Because a lot of our interventions are individual level, and an individual level intervention assumes there's something wrong with you. That's the underlying assumption. There is something wrong with you. And if we just change you, we give you something to change your life, it's going to be great. But in the context here in South Africa where we're doing our research, there's something wrong with the context. Those contexts are not livable. They're not designed to create and result in lives that are prosperous, where there's thriving. And I'm not at all shooting against individual level, but I'm wondering, what does it say to us?
Okay, just going to give Dr. Zoe just to respond on those.
Can you hear?
Yes.
Okay. Thank you for your questions and comments. So I think, firstly, I mean, the qualitative, there was so much data, and I focused, I mean, the title was kind of, is it making a difference to the lives of young women? And I focused very much on the self-reported, it was a very positive overview of the perceived impacts. And things like PrEP discontinuation is a whole nother topic which needs to be focused on, and we do have analysis focusing very much in on that topic because it is a huge problem. But the same thing with contraceptive, it's not just about access, it's about ongoing use. And we've actually just focused one piece of analysis on this, on contraceptive journeys, and the same with PrEP journeys. It's not about meeting, it's just about uptake, supporting that young woman through the changes in her life, her changes in her types of relationship. Migrant children moving around, it's a continual need for access. And so this once-off data is not sometimes very helpful in understanding that young woman's reproductive life journey and all the decisions that are made along that way. So I just, yeah, I think there was one other piece I wanted to respond to with Younger. I think speaking about the framing, this word framing came up in a previous presentation in this session, is really crucial. And that's actually something which we've been looking at, the framing of blame around teenage pregnancy. And this term teenage pregnancy has been used in public discourse, in media, this problem, this social problem. And it's not unique to South Africa. And so policies, how do we solve this problem? And it's very much blaming these young women for their promiscuous behavior, for not putting into place, not enacting safe sex, but looking back at the broader environment and the policy, in fact, and how the blame, the framing of blame is shaping our policy for very individualistic centered interventions. So that's something which is definitely something we are trying to, for a health systems approach, looking more at the systematic issues and not just targeting a young woman's knowledge and her behavior, because those are crucially constrained within the context that she's in. So anyway, that's just a brief response. I don't know if you want to add.
I just want to comment on the structures and how we view the intervention impact. We know you guys have said it well that we're living in a dysfunctional society and there's a lot of other structural issues. So to some extent, these interventions are helpful, but as we've heard earlier on, there's always a primary focus or as a primary need that needs to be addressed. In this instant, HIV prevalence has been a huge burden and impact on young women and girls, and that's what the funders are looking for, the intervention impact on the specific outcome. Not that it doesn't make change on other aspects, but the focus is what they want to reduce or what they want to effect change on. There are other elements that the intervention is doing, and we will dive into further analysis into exploring what the specific change and improvement of lives of young women and girls in this community, but it has factored through the community. As you can see, that the knowledge has improved compared to the first evaluation that we did, which was a baseline assessment of the same My Journey program. And behavior change really takes a long time. We could not possibly expect a very positive and intervention effect in such a short time. At least we've seen it before. We're still talking about teenage pregnancy, but we've had family planning issues in decades ago. So it just shows how far deep into the societies and into the community norms and factors that we need to penetrate. But for now, the agenda is to protecting and equipping the young women and girls. And we are including the young boys and men now for further interventions. Thank you.
Thank you so much, Kim. Unfortunately, because of time, we can't take any more questions. I know this colleague at the back wanted to ask some questions. We're going to move to the next speaker, Prof. Tanya. She's a chief specialist scientist here in our unit, the Health System Research Unit. And then also, she's an honorary professor in the Department of Pediatrics and Child Health at the University of Cape Town, and also an extraordinary professor at the University of the Western Cape at the School of Public Health. Help me welcome Prof. Tanya.
Thank you. Good afternoon, everybody. I'd just like to say that I am presenting on behalf of the STAR team, and my co-investigator, Dr. Christian Horwood, is with us as well today. I'm going to be presenting the results from a cross-sectional survey of person-centered maternity care in rural South Africa. Respectful maternity care is a human right, and it's also directly linked to clinical outcomes for women and newborns. We've had 3 decades of research on respectful maternity care in South Africa, as well as increased global attention on the importance of experience of care as a component of quality maternity care. And this has led to numerous revisions of guidelines and policies, including in South Africa, to include a specific focus on respectful care. We have our 2016 guidelines for maternity care in South Africa, which state that health workers administering care to pregnant women must demonstrate respect, a genuine interest in their clients, and avoid an arrogant, rude, or judgmental attitude. And that this applies even in the context of a poor working environment or perceived unsafe practices of certain pregnant women. Further, our maternal and neonatal health policy, which was updated in 2021, also includes a specific recommendation that all healthcare providers rendering maternal, perinatal, and neonatal services shall provide care to all individuals, women, and their partners in a manner that maintains dignity, privacy, confidentiality, and is free from harm and mistreatment. So the issue of disrespect and abuse in maternity services in South Africa has been well described over many decades, including from colleagues here at the MRC, Professor Rachel Dukes in the 1990s. And we know the drivers deeply rooted in our country's socio-political landscape and inequities between the public and private sectors. But much of the research on experience of maternity care has focused almost exclusively on qualitative research designs and has been undertaken within midwife obstetric units in urban areas. We've had very little quantitative measurement of experience of care and very little research undertaken in rural areas. And so our team undertook a baseline cross-sectional survey in 2 rural districts of KwaZulu-Natal. We recruited almost 1,000 postpartum women within 9 weeks of delivery, specifically recruited from postnatal clinics, not the facilities where they gave birth, as well as some neonatal units for women who had small and sick newborns admitted. Our primary outcome was person-centered maternity care, which was measured on 30 items in a tool with a 4-point Likert scale. So this tool and the derived PCMC scale was developed in a rural and an urban setting in Kenya and subsequently applied in India and Ghana. And this is the first application of the tool in South Africa. And we used this tool to obtain a baseline measure of experience of care as part of a before measurement for an intervention, participatory learning and action intervention with maternity teams in 9 rural district hospitals. What's important about this tool is that it acknowledges that experience of care is a continuum, and so it produces a linear scale that gives you a sense of the continuum of experience. So the 30-item scale has 3 subdomains. The first looks at dignity and respect, and this component addresses issues such as verbal and physical abuse, privacy, confidentiality, as well as the attitudes of healthcare providers. The second subdomain addresses issues of communication and autonomy, and this looks at issues such as whether health providers introduce themselves, whether a woman is called by her name, whether she's involved in care, consents to procedures, whether procedures and examinations are explained, and whether women feel able to ask questions of their providers. The third domain is around supportive care. This looks at waiting time, support within labor and delivery, including control of pain, support for anxiety, trust in providers, as well as issues of infrastructure such as cleanliness and availability of water and electricity and crowding within facilities. So this figure shows the results for the full scale and subdomains from our sites. Overall, we have rescaled this out of 100 for ease of interpretation. And overall, we found a score of 62% for the full scale. The highest scores were obtained for the subdomain on dignity and respect at around 80% of the maximum value. Importantly, we found quite stark differences in the experience of care between women who had vaginal deliveries and women who had cesarean sections, which make up around 1/3 of women in these hospitals. The worst performing area was around communication and autonomy, particularly for women who had vaginal deliveries, reaching only 50% of the maximum score for that domain. The advantage of us using a validated tool that's been used in other countries is that we're able to compare South Africa to some other settings. And across all the countries where the scale has been used, the PCMC scores were below 70 out of 100, with overall experience of care in rural South Africa being lower than both the urban and rural settings in Kenya, and similar to what was being reported from India. Across all countries, the domain with the lowest score is communication and autonomy, and this is clearly an area of need for improvement across these settings. And for South Africa, we scored particularly low on the supportive care domain at around 60% of expected maximum values, and lower than what has been reported from both Kenya and India. So there were several areas where experience of care was similarly poor, irrespective of mode of delivery. Despite both our maternity care policy and our guidelines strongly recommending companionship in labour, and a Cochrane review showing companionship in labour to be one of the most effective interventions for improving respect in labour and delivery, we found that only 6% of women were allowed to have a companion with them during labour and delivery. 1/5 of women reported experiencing verbal abuse. Only half of women felt that their information would be kept confidential by providers. And overall, around 2/3 of women felt that they were treated with respect during the entire time that they were in hospital for their delivery. We also found some stark differences in certain aspects of care between women who had vaginal deliveries and women who had cesarean sections. Women who had vaginal deliveries experienced less privacy during examinations. Less than half of health providers introduced themselves when they first came to see them in labour. They were less likely to be asked permission for examinations and procedures, less likely to feel that they could ask questions of their providers, and felt that their pain was not well managed compared to women who had cesarean deliveries. So in a multivariate linear regression model accounting for all other predictors, we found that women who had attended 8 or more antenatal visits had a higher experience of care score overall and across 2 of the subdomains. We also found that overall women who had a cesarean delivery experienced higher quality of care, and older women reported higher quality of care compared to young women aged 16 to 19 years. And overall, women who delivered during the nighttime experienced worse quality of care compared to women who delivered during the day. So these results suggest that there are important areas for improvement within the South African maternity care context, in particular in relation to communication. Women who had cesarean deliveries reported better experience of care, and although the experiences of care were still far below what is acceptable levels for women who had both modes of delivery. And this is the first time that experience of care amongst women who've had cesarean delivery has been measured in South Africa. So women are continuing to experience disrespect, and they have a lack of trust in a health facility environment where they have very little involvement in decisions around their care, and felt unable to ask questions of their providers. And so this supports the need for interventions that address organizational cultures within health facilities that are allowing disrespect to continue. Particularly aspects of care that require attention include fostering trust with providers and encouraging respectful communication, particularly amongst women who have vaginal delivery, as well as openness to companionship in labor and delivery. The KwaZulu-Natal province has recently issued new minimum core standards for maternity care applicable to that province, which now lists companionship in labor as a required minimum standard. And so we are hopeful that things will start improving with these new minimum core standards. We also know that interventions that try and address respectful care cannot only be focused on staff on day shifts, and we need to incorporate staff working on night shifts as well. Thank you.
Thank you so much, Prof. Tanya. I'm only going to I'm going to allow one question from the floor. We have little time left for the second speaker. Any questions? Okay. Thank you, Prof. Our very last speaker is Prof. Dash. She is a specialist scientist here at our unit, Health Systems Research Unit. And also her papers focusing on HIV treatment outcomes along the care cascade, linkages to HIV care, mental health and well-being among vulnerable groups. Ladies and gentlemen, Prof. Dash. She's very short, so yes. I'm not sure if you...
Thank you for highlighting that. Okay. Great. I know lunch is upon us in a few minutes, so I'd like to get all of your attention. So perhaps we just roll our shoulders back as an icebreaker. Hey? Great. So we heard from this morning, under the UHC umbrella, as we know, there's ambitious objectives to provide full range of health service to everyone when and when they need it without financial hardship across the life course. However, we know that talk is cheap, and the reality is investing in the health and well-being of the most vulnerable in our society does mean significant additional costs, and thus movement towards UHC for vulnerable populations in the context of tight fiscal constraints is likely to be much slower or non-existent. So a case in point in the area of women and girls. So large-scale economic evaluation of violence against women and girl prevention interventions in 6 LMIC countries, such as Pakistan and other sub-Saharan African countries, led by colleagues at the London School. And speaking of PhD supervisors, my PhD supervisor, the first author, and colleagues in our Gender and Health Research Unit at the MRC, found that established programs were cost-effective. However, these came at a price. High upfront implementation costs, particularly for new community-based programs. As many of us know, tackling a structural driver such as this means you gotta start up from scratch, putting in the infrastructure as well as staffing cadres that don't exist. So these drive up the startup costs. However, authors do provide ways that these costs could be offset by adapting the program to reach economies of scale. The paper also highlights low cost-effectiveness probabilities for interventions involving hard-to-reach groups. And so go figure, these groups have lack of access to services, encounter multiple structural barriers, poverty, gender-based violence on a large scale, and stigma, hence more resources to reach out to them and bring them into these community groups. Results also indicate equity trade-offs, particularly for school-based programs. So whilst it's cheap and integrated within an existing system, the problem is the equity trade-off here is that you miss high-risk, out-of-school youth who could be particularly more vulnerable. But however, promising results, right? And for a structural driver that's common and cuts across many of the disease condition, promising enough to take these to scale. But that's not happening. And hence we see a lack of explicit investment of equity-focused programs, particularly for women, children, and adolescents, as noted in our recent unit piece that dissected the minister's planned healthcare budget allocation for 2024. However, regardless of the price, we can all agree that improving maternal, child, adolescent health through some of the interventions my panel just shared is a moral imperative, as well as legal and constitutional. Hence, there's an urgent need to demonstrate both the long-term impact and cost savings through robust economic evaluations, given the competition with other health programs and a constrained healthcare budget. So what are the health economic methods that we can use to support the direction of funds towards vulnerable groups? So just a quick crash course. So many of us are familiar with this conventional economic evaluation method, cost effectiveness analysis. You've heard people talk about it, basically comparing the costs and effects from two or more programs through calculation of an incremental cost effectiveness ratio. So the focus of this approach is to maximize health at the lowest possible costs. So the green tick is where you want your new program to sit. So basically providing the most amount of health gain at the lowest cost. However, you do encounter challenges with this approach when evaluating equity-focused interventions for hard-to-reach groups, as the focus here is on selecting a program that maximizes health gain for the general population. And also, there's no explicit analyses of the opportunity cost. So Musa spoke a lot about the cost on the patient side. Also, the opportunity costs related to taking away public resources to divert it to this new health program. So it could disproportionately affect marginalized groups that could be dependent on the specific public resource that you took away. And like colleagues mentioned, many of the evaluations have a short time horizon with narrow clinical markers of success, making it very difficult to observe large gains and compare across multiple programs. And also, there's a lack of focus on efficiency equity trade-offs being explicitly made. Whilst previous cost effectiveness analyses have looked at the trade-offs using simplified methods by looking at net gains losses, such as the AID for the AIT program that Susan Cleary has published on. Some health economists have weighted outcomes by socioeconomic status, and some have looked at the reduction in financial risk. However, these are simplified methods that get critiqued a lot in the literature. And so an emerging method, or recently published, distributional cost effectiveness analysis. So it's a type of equity analysis gaining a lot of popularity in HTA bodies in the UK. And it's basically about comparing efficiency, the value for money, against equity distributional impact. It incorporates population surveillance data and takes into account in some analyses, as you'll see, the life cost approach. So I'm no expert in this method, but a 101 because I hope to use it soon. So essentially, if you had an intervention and you want to look at it from an equity lens, ideally you want to sit on the plane that's a win-win. So cost effective and improves equity, right? That's what we all are aiming for. Or it could be cost ineffective, where you choose the basic standard of care, lower cost, cost ineffective, but improves equity. Sorry. So an example of a lose-lose, very common. So as Prof. Nicholas Chris spoke about, high-cost treatment available in the private hospital. So small health gain for a very small, wealthy population. An example of a win-win program here is childhood vaccine programs. Total health gains at the general population level, also very good for vulnerable groups, socially deprived groups such as rural children. Oops, sorry. An example of a win-lose situation is an advanced pediatric cancer treatment available in public hospitals only because of the resources needed to implement this. So one would say not good, harms equity, but there's two ways of looking at this. You could re-strategize, subsidize all those coming in from the rural areas in terms of transport, living, or you could choose the lose-win, standard pediatric cancer therapy available in all hospitals. So just some examples of where this type of method could be particularly useful for some of us involved. So you would have heard about CAB-LA being evaluated, HIV PrEP injectable. So some tough decisions to be made. How do we fund it? At what price? And which population subgroup should we target first? AGYW or mobile men? And it's being implemented in rural KZN and Eastern Cape as we speak. The other aspect is coverage in healthcare benefits package. We're talking over lunch, and this could be really vital for that piece in terms of what should we cover for older persons, which treatments, what co-payments. And then there's also where do we invest in terms of community-based, gender-based violence program, how to select the target areas. And then something that's come up frequently in today's discussion is life costs. So an extension of the distributional cost effectiveness analysis. So I'm just going to speak about a paper recently published by Skara et al. So here the authors evaluate a parenting training program for parents with children with conduct problems in the UK. It's called The Incredible Years. So here the authors use a life cost approach and seek to use the well-being outcome as a measure of success, aligned with SDG 3. And they draw on trial as well as longitudinal population data. Sorry, my hands. So in terms of the basic analysis first conducted, so the authors find that there is a high total upfront cost of the program if you give it to all eligible child-parent diets, so all parents with children with a conduct problem. There is a cost per health gained, which is below the threshold, so cost effective. Lifetime savings, though, only seen 15 years post-delivery. So can a policymaker wait that long? And so the authors then model data using surveillance data to see, can we potentially retarget to increase the value for money for this intervention? So they do that by retargeting the data to only select vulnerable child-parent dyads, so parents living in poverty with children with severe conduct problems. And here you see trade-offs. Well, it's a reduction in upfront program costs because now they don't have to take it to the entire pop. It lowers the cost per good year gain, so good year, well-being, cost-effective. There's an increase in lifetime savings. However, the trade-off here is then there's a reduction in total good years, well-being gained at the population level. So just giving you a flavor there. And so what does it mean for our focal area that's focused a lot on the economic evaluation of youth and caregiver mental health and well-being interventions? So Stanley Carries in the audience, so specialist scientist and PhD student, is currently co-developing a well-being measure specific to answer the question that Lungi had posed, the need for broader outcomes to evaluate these multi-sectoral interventions, similar to what Kim had described. And his work will be embedded within a SAPRIN surveillance node, so the Singer node in KwaZulu-Natal. And then we have Audrey Moyo on the top. You can wave your hand, Audrey. Also drawing on surveillance data sets from nodes under SAPRIN to evaluate the correlates of mental health among young adults in South Africa. So both pieces of work really essential for enhancing our health economic modeling studies for the country and region as a whole. Forgot to move that. And then in KZN, we are wrapping up a pilot cluster randomized trial evaluating a cash transfer economic empowerment intervention for caregivers of children and adolescents living with HIV in peri-urban and semi-rural KZN. Unfortunately, we couldn't find an NGO partner or partners in its non-existent provision of gender-based violence care and support in the area we work. So much of the implementation we had to do on our own. And so whilst we tried to reduce costs as much as possible, there is significant implementation costs when it came to rolling out this type of intervention, as we had to start up much of the aspects from scratch. And now we're evaluating, we're at the end line, and we hope we'll see some sort of offset in the implementation costs as drawing on the methods that I spoke about, hope to apply these to really model them into the future. So my team, our data manager, Nokwanda Sitola on the top, following up our 140 intervention and 140 control participants to see how the intervention has impacted them in terms of well-being, and also just qualitatively start following up the participants who have used intervention resources to start their small income generation activities. And the picture there just highlighting the women on the left who started selling fish with the money and the skills learned from the program at local hair salons. So in conclusion, so equity-focused economic evaluations dependent on two aspects: inclusive and larger trials, which come at a price as well, and rich population-level surveillance data linked to public sector records, like has been highlighted previously. However, we know that health economic data are not the deciding factor when it comes to decision-making. It's more complex, a lot of ethical, political, and other economic factors at play. And also, it's not just about the distribution of health, but also the capability of people to achieve good health, as noted by Nobel economist Amartya Sen. And so the question, how do we target these now? Almost there. So for vulnerable populations, essentially, something's got to give, as you've seen. And it is about putting your money where your mouth is when it comes to health equity. Thanks. I'd like to just acknowledge my team, funders, and collaborators.
Thank you, Dr. Dash. Indeed, she was not short. Okay, I'm just going to give just 2 questions before we close the first oral session. Just 2 questions. Okay.
Thanks so much. Dasha, it was very insightful. I'm just wondering, you specifically mentioned some Andre from Saprin, and you specifically mentioned about the value of using population-based data. And I don't know, like, why is that an advantage? It's like, why do you think that we should be looking at that and rather using cross-sectional data or panel studies, etc.? Thanks.
Okay, number one. For anyone who's ever run a trial, we know that we don't get a lot of money for running these interventions. And so embedding it within existing surveillance nodes, really valuable. The need to look at it from a longitudinal lens is because, you want to look at the lifetime gains over time, right, essentially, which a cross-sectional won't be able to give you. And in a demographic surveillance where you're following people over time, you can watch these trends very closely, not only look at the individual effects, but also the household effects at the community level. So its ability to measure these broader lifetime gains, basically.
Hi, Craig Lund from UCT and King's College London. Yeah, thanks so much. Great presentation. I'm just really interested in your intervention because often within mental health, we see economic returns on the investment accruing to another sector of society at some point in the future, what's sometimes referred to as kind of diagonal accounting. And so it becomes really important when we're thinking about prevention or promotion interventions, especially for mental health among young people, to be thinking about whole of society costs over the long term. So I really like what you had to say, but I'd be interested to hear if you had any further comments.
I'm going to draw on Janella there to help. Yeah, I mean, the double counting, the other aspects, it's such a challenging situation. And the only way we can sort of get to it if we have some empirical data to also look into, do some sensitivity analyses, because right now it's thumbsuck, right? Unable to really measure those things until we have these large-scale, longitudinal, where we have some way of trying to capture and mimic and model cohorts and be able to just unpack a bit more. Janella, do you want to shed light on that? It's beyond me, beyond the methods I know.
No, I mean, I think you answered it quite well. I think, definitely when you're doing an intervention like that, you want to look at the cost savings incurred in other sectors. But the issue is as well is that each sector is, I mean, unless we have kind of shared funding mechanisms as well, each sector is very focused on what the cost savings there are on their own kind of sectors, and it's difficult to say there are incurred savings, say in the correctional service department, as a result of an intervention the health sector is delivering. And so, I mean, it's a big challenge, and what we're trying to push for is some sort of kind of conditional grant mechanism where it is bringing in multiple sectors, but we also need some sort of unified information systems that can, something that's relevant to all sectors, and that's really challenging to find as well. So, but also, sharing across sectors of information systems we really don't have at the moment. So it's really difficult to capture that offset benefit to other
maybe
sectors.
if we finance it through a central, we'll be able to measure those and capture that. Yeah.
May I add something? So I mean, I think it's the same thing that we see with adolescent sexual and reproductive health interventions in the educational space, which accrue benefits to other sectors like social services and education and health. And so I think particularly maybe the thing is to, when we create interventions or plan interventions at the beginning, to actually bring in, even if we have a conditional grant, but to bring in the sectors to understand what outcomes are important across the sectors, to be able to measure them and include them in economic evaluation, like Lungi was saying, because we tend to measure one from a sectoral solo perspective. But if we have an understanding from the beginning when we create interventions, then we're able to, say, have real-time outcomes which we don't have to model necessarily.
Thank you so much, Dr. Dash. I think this brings us to the end of our first oral session. I'd also love to just thank our wonderful speakers for making time to share knowledge with us today. You guys are wonderful. Thank you so much. And also, just give you guys also a round of applause for being such a wonderful audience as well. So for now, we're going to move to that other room. But before that, we're going to take a group photo just in front. Here. We're going to close the door. No one will. Yes. Okay, thank you so much.